just signed out. Now it's time to tune in. Welcome to Sign Out with Kyle the PA, the commute companion for PAs, PA students, and pre-PAs. Real stories from real PAs across every corner of the profession. Your journey continues here. Here's your host, Kyle the PA.
Welcome to Sign Out with Kyle the PA, your go-to show for the commute. I'm Kyle, bringing you stories and candid conversations with physician associates, making a difference in Asian health across the country. Tune in for inspiration, laughs, and insights to kick off or end your workday right. On today's podcast, we have Viet Le. Viet is an associate professor of research at Intermountain Health and Preventive Cardiology, PA with over 20 years of practice. He has a bachelor's in exercise science, athletic training, a master's degree as a physician assistant from the University of Utah School of Medicine, and his doctor of medical science and health professions education from Rocky Mountain University of Health Professions. He co-directs the Preventive Cardiology Clinic at Intermountain Medical Center, Intermountain Health, and serves as an investigator on multiple sponsored investigator-initiated cardiovascular clinical trials. He has co-authored over 50 publications. His current healthcare foci are patient-centered care, improved shared decision-making processes, cardiovascular kidney-metabolic health, and preventative cardiology. He is the past president of the Academy of PAs in Cardiology and Utah Academy of PAs, a past co-chair of the American College of Cardiology PA work group, and has served on several ACC committees and is the editor-in-chief of the ACC CardioSmart Committee. Viet, it is an honor and a pleasure. I'm very excited to have you on the pod. Thank you for joining us today.
Well, thank you so much. Hopefully, folks get a chance to hear some of the smarts that sounded pretty good in that profile.
I mean, the profile sounds great. I think we're gonna hear a lot, and I wish we had even more time to talk with you, but like I said, and like we said, this is supposed to be something that's, unfortunately, in the case of this episode, short and sweet and something that people can listen to on their commute. But I just want to start, just reading your intro and reading your bio. How many years have you been a PA for?
Yeah, I started in practice in 2004. So just about 21 years. Yeah.
21 years. So if you can't, I'm sure this is probably even tough for you to do, but like in your past 21 years as a PA, how would you, I get actually an even better question. Where did you start your career? What was your first job as a PA?
Well, I was actually hired out of PA school. Now, a common tenet of PA school is that you do not work. I broke that. I was a cardiac therapist at LDS Hospital with Intermountain on the weekends through my first and second years of PA school. And as a cardiac therapist, I was leveraging my exercise, science bachelor's degree. I encountered all the cardiologists and cardiac staff at Intermountain at the time. And so they just offered me a job in my last month of PA school and said, just come work with us. So that's where I got cut my teeth as a PA. Newly out of PA school, was right into a cardiology practice.
Wow. So you've been there for a long time then.
Yeah, well, I think I also fit the average career changes for PAs. I left after just under 2 years into occupational medicine, and then worked at the Salt Lake VA Medical Center, now the George Wallen, for about 6 years in occupational medicine, and then came back to cardiology in 2012.
Wow. Okay. So you've seen some changes. You've also been at places long enough to see, the development in your own position and with a single practice or place. That's really cool. I certainly have some questions I'd love to dive into. We obviously met through Alex, and Alex tells me you're an incredibly busy guy. So tell me, I guess just what a typical week looks like for you, or a typical month looks like for you. I know you're you're traveling, you're doing research. What does that look like?
Yeah, I probably be more fair to say, what does my atypical week look like? So a typical week for me is really, I think, atypical for most people. What it should look like, how it is scheduled out, is I have two half-day clinics, a Monday afternoon and then a Tuesday morning half-day clinic. One is general cardiology, the other is preventive cardiology, which is really a CKM, cardiovascular kidney-metabolic clinic. It's purely consult, and then I shift patients over to my Monday for follow-up. The rest of the time is very flexible to my hours as a a clinical scientist. So I have zero point 0.7 designated protected time for research. And what does that mean? I mean, people are like, are you in a lab pipetting, or, are you looking, what are you doing? Because when you say research, this thing comes out in people's head. Well, clinical research is a little bit different because it looks a lot like what you do in clinic and maybe in the hospital, etc. But I'm running research protocols. I'm overseeing inclusion, exclusion, screening, etc. On these large scale sponsored trials, but at a singular site at Intermountain. So, there's a lot of time spent in research meetings, whether it's designing or reviewing protocols, following up on current trials that we're already running. And I mean, it's mattered throughout. And so when you're, either PI, principal investigator, or a sub-investigator, that's a lot of meetings. If it's 5, 6, 7 trials and then registries, and then we're constantly trying to publish. And so you're talking with your, publication team, the co-authors, et cetera. You're looking at data sets, and you're always designing the next thing or putting together abstracts for conferences, which, I attended 18 different conferences this year, 3 or 4 of which we submitted and successfully had accepted abstracts. And so presenting there, yeah.
Wow. Thank you for sharing what that looks like, because I think for a lot of folks, and I think for the vast majority of PAs, we work in clinical medicine. Many of us, though, I think work in clinical medicine in a setting in which there's a lot of academic medicine and clinical research happening alongside us, but we may or may not actually be tapping into that side. So it's so cool. It's so interesting to hear someone who has a foot in each side. And as a PI, I feel like a lot of times we just think to ourselves like, oh, clinical research and research is really reserved for attendings, is reserved for MDs, like that's their thing. Like we just do the clinical side, but there's obviously so much that we have to offer as PAs, as evidenced by your career. So, tell me what inspired you to start doing research, and what have you always been interested in research, or what was the transition like from going from what sounds like probably mostly a clinical career to now like a very research heavy career?
Yeah. No, I when I went into PA school, I thought I'd be an orthopedic PA because my undergrad is exercise science, and I was an athletic trainer. I was actually certified as an
Oh,
athletic
wow.
trainer. Yeah, and I was a head athletic trainer at a local high school for the first, for a year, teaching and out of a PT clinic. So research was like, I don't even, I mean, you think now, if you're asking the question, you're like, can PAs do research? I mean, 20 years ago, that wasn't even a thing. So, this happened by accident. I was a clinical cardiology PA, did hospital. I was supporting 13 different physicians in the kind of wild west of subspecialties then. They're a little bit more organized and structured at this point in terms of cardiology subspecialties. Then jumping into my time in OCMed, that actually wasn't clinical occupational medicine. I did compensation pension, which is totally different. People that might be a different episode to talk about, but compensation pension is really an important part of how veterans receive their disability payments or receive, disability, period. And so it was a lot of disability evaluation, assessment, and evaluation of whether this injury was related and therefore can be service connected. It was really interesting. And I did a lot of literature search. I had to dive into, because, you think of like diagnosis is one thing, but then was this caused by something else is an entirely different set that you and I don't think about in our clinical medicine. We just say, okay, we see the disease. Yes, let's treat the disease. But we don't really think about the cause, and especially in orthopedic type of injuries. But I also did chronic disease assessment too. A lot of Agent Orange, whether diabetes, prostate cancer, heart disease was related. So I was already diving into literature, but that's something that someone already produced. When we lost our contract at the VA, I was never a VA employee. I was a contractor. When we lost that contract, there was a year time frame where I thought, I want to come back to cardiology. And so I reached out to my team and they said, well, that's great. We'd love to have you. In fact, they'd been reaching out to me through the 6 years that I had left. They said, but all we have is a research position right now. I'm like, what? You know who you're talking to. I'm like, I'm a clinical guy. I don't know how to do research. And he said, well, that's great because we don't know what to do. Also, we just think it's a great idea to have a PA help us in research. So I had the opportunity to build it from the ground up. I basically said, look, everything that we do in clinical medicine in a collaborative role with a physician attending, that translates very well into clinical research with the PI, sub-I, and I would do basically a lot of the same things that the PI did as a sub-investigator. And I just said, okay, let's jump both feet in. I read all the publications and things, but now we're on the side of creating it and doing the trials that lead to our understanding. The one tip I would say is, look, it's real cool. I love seeing patients, and I think I'm a great clinician. I think so, and maybe that's a little bit narcissistic. I'm just saying I love seeing patients, but you can only see so many patients in a day. And so it's a one-to-one interaction. You might be double, triple, quadruple booked. But when you can be part of clinical medicine and research and improve our knowledge of things, you move good practice to better practice to best practice, and then you change guidelines. So the things that I've been a part of, like say the SPRINT trial and what changed in the hypertension guidelines, my influence now goes from one-to-one to millions. And that is so cool to think about, is to be part of something that changes practice, not just for me, but for you, Kyle, for everyone else that touches a patient that has blood pressure.
Wow.
Pretty cool.
I love that case that you're making for doing research as a PA, because you hear so many clinicians, so many PAs, so many PA students say, I'm getting into it because I want to help people. But I hear the case you're making, and you're like, I can help someone one-on-one in the office, in the clinic, in the hospital, but I could also do something that changes guidelines that helps thousands of people,
Yes.
And the reach is so far.
Yeah.
And it aligns with that goal that many of us have, which is to help people, but in a much different way, and I appreciate that. I love the idea of, of PAs not saying no to these opportunities because they're there. And you and I talked about this, is that the opportunities for PAs and research are there.
Yeah.
You just have to kind of, what do people say? Keep an ear to the ground, or just like kind of be keen to it, right?
Well, that opportunity, we say this, opportunity knocks, and sometimes it's a soft knock and you're just not paying attention to it. It's there and it's like in your periphery and you're like, something's tickling there. And if you just look and you're like, whoa, that's kind of cool. I would like to be part of that. And as you jump in, you realize, wow, there's so much more here. It is way cool. So the one part that I mentioned is, as guidelines, as I get to influence guidelines, I'm also practicing at the front edge of medicine if I'm in a clinical trial. If I'm a clinical trialist, the things, just back up one step. When we develop a clinical trial, the whole reason for that is because we develop a background and say, these are the opportunities. This is the gap in current care of, let's just stay with blood pressure. And we say, look, currently people managed at less than 140, yeah, okay, we think we're doing good, but what happens if we manage them to less than 120 on their systolic and, diastolic, et cetera? There's a gap in our knowledge there. And as we were practicing forward as clinical trialists, that bled over into my clinical treatment of
Mm.
patients because I recognized, being kind of forced to do it by protocol, that this was okay. It was safe to treat patients to less than 120. Turns out it reduces mortality by 25%, but we didn't know that until the analysis was out. I was already practicing that, and I can translate that to my clinical partners and say, look, it's doable. Not only is it a guideline, but let me tell you how it was done as a clinical trialist in Sprint. So it's cool to be able to do it at the same time. It levels up my practice real time, and then the guidelines, of course, are 3 to 5 years afterwards, after all these trials.
Yeah, I love that example that you bring up, and now that you mention it, I see it even in my own practice as a clinician. I work in interventional gastroenterology, and the attendings that I work with are like many attendings who work in like academic medical center. They're obsessed with research, obsessed with trying to push the envelope, see how to make things better for patients, how to improve outcomes. And so they're constantly trying to do new things and push the practice of gastroenterology, specifically interventional gastroenterology, forward. And what it results in is that our patients, I think, get better outcomes,
Yes.
because they're always looking to find a better way to do things, find a new way to do things, and look at where those gaps are and see something that, an area of research that needs to be expanded on. And so our patients, I genuinely believe, are getting really, really great outcomes, and the research is coming out to support that. And
Yeah.
so it's really exciting to be a part of that. And speaking to that, the other point about I love I love that idea of the soft knock. That's
Yes.
so good, the soft knock. And for a lot of PAs, I really encourage, if you're working in a setting in which there are researchers around you and people doing research, it can't hurt to just ask, see if
Yeah.
there's a way you can get involved in something that you and I have talked about. You've talked about too. Like, I'm sure you're always needing help on research projects, right? You could always
Always.
probably use the help and support, right?
Yes, absolutely. Absolutely. And for the PAs listening in, I know we sometimes we suffer from imposter syndrome, but the other part is like, well, I don't have any experience in this. The, Look, the director of my cardiology group when I was first out of PA school, and then who ended up being the director at Intermountain. That was a private cardiology group. They got absorbed in Intermountain. So when I followed them to Intermountain, Don LePay was there again. There were three things he launched me with, and we had many conversations. He said, Viet, I love your smile. You're affable. Stay affable. I love how you're available. You always say yes to everything. And there were 13 physicians that I was covering. So it was like, I'm doing 13 different jobs. And able, affable, available, able. Notice able is at the bottom because you become able as you become available and you're affable to say yes to things. The experience comes. We know this. We're PAs. We have, 1 year didactic, 1 year clinical, and then we just jump in. The rest of the time, we are eternal residents and fellows. We're always learning. So you will learn those skills. It will come, but be affable. Be like the fun person to play in the sandbox, and then be available. Say yes, and the experience comes. So that soft knock, okay, say yeah, okay, let's do it, and you will learn.
Yeah, that's a great point. And I think um one thing that I constantly I'm thinking about when I'm getting involved in like any sort of like it was a lot of times I feel like research projects or things that I previously thought was really reserved for MDs, is I try to tell myself to put my ego aside, put my pride aside, and allow myself to just be a student, learn, and just, you said, just be available and just be ready to help. Even if that means I'm doing work that's adjacent to maybe a medical student who's also on the research project, that's okay. I'm able to be a part of the project, and I'm going to learn in the process. And just like that medical student who's going to, graduate to become a resident and then essentially become a fellow and attending, then they're going to be, PI on projects. Like, I'm going to my knowledge of research will graduate up. And, you know, right now, maybe I'm doing some work that's one smaller cog in the wheel of this big project, but eventually I'm going to start to build that, you know, foundation of understanding of how to do research and what to do with research. And, you know, but that definitely takes a little bit of like putting the ego aside. Like, it's okay that I don't know much now, but I'm going
Yeah.
to learn.
Exactly, exactly. And that's, I mean, I think that was partly baked into the philosophy of being a PA, right? Is really we were not uh quote unquote designed. We were not designed to have to know all. We were designed to be a very versatile, flexible profession that would grow in through our entire career and really partner with our physician attendings and our colleagues. And honestly, come on, you tell me that your attending doesn't call another attending and say, "Hey, I don't quite know what this is, and can you help me think through this?" This is like a PAMD talking to one another, right? And I have a lot of colleagues that refer patients to me, physician colleagues who refer patients to me for lipid management, for management of certain parts of the CKM. You know, they've never prescribed a GLP-1. They don't feel comfortable with SGLT inhibitors. And so, you know, they run a patient by me. And so it's fun. I mean, this is, you know, it's great. Medicine is a team sport, but recognizing that even our physician colleagues are calling one another and asking questions. So we should not feel in any way inferior or like we don't know anything because it already comes with the profession that we are learning. It was designed that way, that we will always be in a team setting.
Yeah, I agree. And that actually brings me to, you know, one of another point that we've talked about before, and that's about, you know, mentorship and the profession. And you know, we've talked about, and something I've always said about the PA profession is that, and then you kind of highlight too, is that the profession, you know, we're going into school, it's 2 years, it's fast paced, you're in and out, and it seems like anytime there's not a lot of time to build a sense of mentorship. But then we're also in this profession in which we're supposed to be perpetual learners. And with learning, you know, obviously mentorship would be great to have in those cases. And our MD colleagues have a lot of mentorship built into every step of their training because they need it and they're in it for a long time. And I guess my question is like for you, like what do you see as the role of mentorship in your own career, the future career of PAs, as researcher? Like, did mentorship play a big role? You know, just talk to me a little bit about that.
Yeah, this is fantastic. You know, Kyle, as we spoke about, it's very intentional in the physician career, in the makeup of their profession. I mean, you know, they start from the bachelor's to medical school. They have an intentional residency fellowship that can be anywhere from 1 to 5 years, depending on what subspecialty they go into. Meanwhile, it's like, you know, we 2 years, and they're like, fly, be free. And and our profession doesn't have that intentionality of capturing people after that point. We've talked about residencies in PA profession. We've talked about fellowships. And I say yes, but also we're so versatile and flexible. People think, well, does that lock me in? And no, but it is time spent. You know, it is time spent when you sign on to a fellowship, etc. So it can be a little bit weird that way. We do need to build that intentionality for PAs, and many of those things happen in associations like the Academy of PAs in Cardiology. We're trying to build that so that you have collegiality, you have mentorship within a group of experienced PAs who happen to have stayed in cardiovascular medicine. Mentorship for me, I mean, I mentioned one, Don LePay. Dr. LePay was fantastic. And who, I don't know, maybe it was because I was affable that he was like, well, I'll take Viet under my wing. And he did again, you know, when I came back to Intermountain and helped foster my career in research, but also my physician partners, Brent Mielstein and Jeff Anderson. They jumped both feet in, but both of them were so used to teaching residents and fellows, they were like, okay, let's teach the PA how to do this. And I started by saying, let me help you think about how to train me. Just think of me as a resident in training and click. Okay, we teach residents all the time. Let's just do the same with Viet. So that's what I would say is if you have a physician partner who's willing and just they're like, well, I don't know how to train a PA, just say, look, think of me as a resident. If you want, think of me as a fellow if I've been out 5, 6 years, whatever. You don't have to teach me the basics of things, but here we're getting into the nuance of whatever specialty this is or whatever research. Now we're moving next level. So in my life, the mentors have come, I think, because I've always been open to saying, hey, I don't know about that. Can you help me? And I would always bring questions. But of course, it would come with research first. I would say, look, this is how I understand, this disease to be in the process, but I'm missing some things in here. And they'd be like, wow, Viet, okay, he's thought about this. I don't have to teach him as if, he's like first semester in PA school, but he's actually thought about this. And then we have a great discussion and we talk about, treatment of this or this nuance, etc. And so I think that's really it. It's incumbent on both sides. But boy, if we can come with a little degree of foundation in what we're asking, they're so happy to reach down and pull us up with them.
I agree. I really like what you said about helping them understand how to teach you, how to mentor you. And I've had this exact conversation before with gastroenterologists in my department who tell me, I was never trained in how to work with a PA. I was trained in how to train residents. I was trained in how to be a senior to my MD colleagues and a co-resident. I was trained in, being like an attending to residents and fellows, but I was never trained to work with PAs. And so I don't know how to, but I want to.
Yes.
And PAs are such a great asset to our team. I want to work with them effectively, but I don't want to offend them by treating them as trainees, but I also can tell where there are gaps of knowledge and I need to know how. And I love that you say like, we need to go to them and tell them maybe or ask them for their help and let them know like, here's what I know, here's how I can help, but can you help fill in some of these gaps? And
Yeah.
I see that work really well. It sounds like it's worked really well for you.
Yes.
I found it to work. I found to work very well for myself too. Like I work with in my role, I work one-on-one with an advanced gastroenterology fellow who is who has already finished general gastroenterology fellowship. So he could be attending, but he's doing an extra year of training. And so in those settings, like because I've been in my role for a couple of years now, he's always telling me, you saved my butt. You helped me out so much. He was like, you know more about advanced gastroenterology in a lot of ways than I do. But I'm like, but I don't know about general gastroenterology as much as you do. And I need you to help me fill in those gaps in my general gastroenterology knowledge.
Yes. I love that. I love that partnership. And really, instead of like this strife and this feeling like we have friction, it's just like, hey, I have stuff to give and I'm willingly doing it for the patients, but also to support you. And in turn, let's just make our team better. I just love that. That's fantastic.
Yeah, it's all about the collaboration. It's about, it takes the right kind of physician partners to have that kind of relationship as well. Like both of us, kind of remaining humble and wanting to help one another as much as possible and putting the patients first and keeping in mind, like, this is really to try to improve patient outcomes, and improve our service, our teamwork, our department to be better. And so, I hope that there are more of these formalized kind of conversations about how do we work with our physician colleagues? How can our physician colleagues better work with us? And I agree too. I think that there are some, there's a big role for like these external organizations or these like third-party organizations to help kind of facilitate mentorship roles for folks who are in specialties and subspecialties. So I want to keep asking you a little bit about your career. So you've obviously had a impressive, decorated career. You have this, title that I've never really, I don't know if I've ever seen from you. You have an associate professor title. Like that's such a, for our folks who are listening who don't work in like academic or clinical research, academic medicine or clinical research, or like work at academic center, like that is a title that I really only see from like my high up like physician colleagues, so and attending colleagues. So it's very cool to see that. But I want to hear from you, like, what are some of your proudest achievements or moments as a PA, as someone who has so many accomplishments?
Oh, you humble me. I would say, and I make this joke all the time. I feel like the Forrest Gump of PAs. I've accidentally fallen into like different pieces of history, but I mean, more than anything, what I hope to do is to maybe be the tip of the spear and open up as many doors as possible for those to come through behind me, and also show that those opportunities exist. They exist, whether by accident or whatever. I will continue to try to push the envelope for us as PAs. And so what is my proudest achievement? I don't know. I mean, I think probably just again, it's my superpower and my super weakness is just saying yes, because it builds on itself. When you say yes to something, it moves to a different position. You say yes, and it moves to a different position. But hopefully, it's because I have shown that I'm putting my efforts in there, and it's not like just graduating upwards into something, and that it's a deserved, position. I think. The most proud I've been is developing my current role at Intermountain as a research scientist and APP or a PA. You mentioned, becoming an associate professor, and yeah, I mean, in professorial tracks, you're kind of well on your way. And in my mid-career, late career, I'm knocking on 50, half a century. So I would say I feel like I'm early career still, but maybe I'm mid. Um, it what I've built at Intermountain is an understanding and a normalization that we can do this, that PAs can do this, that not only am I sub-I, but I can be a PI, principal investigator of studies, and that I can sit on committees at Intermountain, and that they want me to be in on high-level interviews of administrative partners, whether it's our senior medical director or, in the clinical or the operation side or the research side. And even now, as we're looking at women's heart director, I'm in on those conversations. I help make those things happen for our cardiovascular grand rounds and our conferences, etc. And I don't know why they pick me. Maybe it's because they know me, but I think I've normalized that PAs are at the table. They're in the room, they have a seat, and they're at the table, and that we can make decisions and be part of those decisions as well. So that's been probably the most proud I've been of my career, is being able to normalize that. And that allows others to fill in behind me. And then my administrative partners, my physician partners say, I mean, it's great to hear, well, gosh, so-and-so can do that. And they picked an APP instead of a physician partner, because they're like, well, yeah, I work with these people. Of course and it's subconscious now. They like, oh, well, Via does it. So yeah, this is okay. PAs can do this. So that's probably been the proudest accomplishment for me, is to normalize that we can be at the table in the room of decision.
It's such a rich image and metaphor that you give, with the spear head kind of, piercing through and then opening up a wider channel for everyone following in behind. And honestly, and I don't know how much people or PAs think about this, but in the history of and I think I've probably said this before on another episode, but in the history of medical professions, ours is new, ours is young. And so we are in this really fertile time where we can demonstrate to a lot of people, both, clinicians and patients, who we are and what we can do, and really set the foundation for the history of our career. Because we are only like 50 years into a profession compared to MDs and nurses who have been around for thousands of years. If you, look at the ways and, putting aside like nomenclature, like if maybe they're called something else, not doctors or nurses, but like the idea of their profession has been around for a very long time, whereas ours is relatively new. And so folks like you, 50 years in the career are setting this precedent that like PAs can be PIs. Like that's huge. And who knows, like hundreds of years from now, we might see a lot of PAs as PIs. And it's because folks like you have done it and demonstrated at an early point in our profession, like this is possible. This is what PAs are capable of doing. And so, I really encourage folks listening to use you as an example to take advantage of these opportunities, not say no to things. And, and just think like, I don't know how to do it, but be affable, be available. And then, as you said, lastly,
Ability
be able.
goes.
Yeah. The ability will follow.
Yeah.
Yeah. Is there, for any of our listeners, particularly ones who are, I also think it's interesting that you think you feel mid to early career. I feel like that just goes to show how much you think that, it's still capable and can be done. But for our early career PAs, do you have any advice for them if they're interested in research or just interested in your track in general, like things to do? I already love those 3 points you gave, but anything else as we kind of wind down or kind of reach the end of our episode?
The other piece of advice that I was given on top of, and maybe it preceded actually those three words of, affable, available, and able. What preceded that was I had an exit interview from a different activity that I'm LDS, and I served a proselyting mission for the LDS Church 2 years. And on my exit interview, that mission president, we can talk about nomenclature later, but he said, look, I love what you've been doing out here, and people love you. Again, it kind of came to this affable nature. And he said, coming back to opportunity knocks, he says, sometimes opportunity knocks really hard, and you open the door and you find you actually are not ready at that time to say yes. So I'm gonna speak out of both sides of my mouth here a little bit. Find those opportunities. They're knocking and they're soft sometimes, and sometimes they're very loud. But what he said is it was about preparation and being prepared mentally. He said, are you ready to say yes when opportunity knocks? Because it will. It always knocks. And sometimes you just don't feel ready. If you say no, say yes, please. But also prepare yourself. What he was saying was, here, you're moving on. You're gonna go into your adulthood. Be prepared. What does that look like? Who knows? But there are some very simple principled things. Always be curious. Always be reading. Figure out. You do a lot of guys, you and gals. You've learned so much as PAs in training, and the question is, do you know why diseases are the way they are? Do you know why we do the treatments that we do? Or is it just, well, blood pressure, I'm going to add lisinopril. But do you actually know ACE inhibitors and understand that pathology and why we use it in certain diseases like heart failure and MI? Recognize that there are trials that were done and that those knowledge gaps were filled. So be prepared. You prescribe these things regularly, so you got that part down. Now it's cool to step back and go, why is it that we use this? And maybe maybe you don't. Maybe you don't know the nuance of it. Learn it, because that's really cool. And then it becomes a really neat part to talk to a patient and say, hey, look, you've got blood pressure, and this is the guideline. But let me tell you why. Because at this level, 115/75, that's normal. And then you have a 2-time increase of risk at 135, like already. And so when we use these medications, we're going to stop stroke, we're going to stop heart attack, because this is what happens when you increase the pressure in a pipe. And the appliance at the end, it doesn't take that much pressure to destroy it. So, you start to think through these things. Be ready by being curious. So just be curious. That's what I would say is all those things are the the intangible skills, the unwritten kind of things that really make you a person that everyone wants to be around. But then be curious, because boy, that will, over anything else, that will serve you in helping your patients through their health journeys.
Yeah, thank you for that last piece of advice and guidance for our listeners. This has been a great episode. I've had a lot of fun talking to you. It's been a pleasure just hearing your thought process about things and listening to someone who, to me feels like a very seasoned veteran in the profession talk about how they got there. And I really hope our listeners enjoy this episode. I hope they take a lot away from it. I know I certainly have. It's been a great privilege, just being able to listen and talk to you and meet with you. And so thank you again. And thank you to all of our listeners for tuning in for this episode. Keep an ear out. We'll be continuing to release more. Continue to follow PAAH and continue to follow Viet's journey and track as a researcher, as a clinician, as a PA who is at the tip of the spear, opening up this large channel for the rest of us. All right. Viet, thank you.
Thank you. It was an honor.
All right. Take care.